Perfect. Excellent. I think Debbie will be joining in a few minutes, but I think we could get started with a few questions. It's really amazing to see the different, look at that. It's amazing to see the differences between all of you when you're, demonstrating the ICSI and the biopsy. There are a few differences here and there. Sheila, you mentioned a case study where you have to really understand how the patient background in terms of clinical manifestation. And does the embryologist need to really know a lot about stimulation protocol and be concerned about it, and also about patient background when handling, oocytes and embryos in the laboratory?
Yeah, absolutely. That's a great question. And my answer will always be absolutely, because we're simply not just lab bench technicians. We work in a high complexity laboratory. It requires some level of analytic skills, actually a very high level of analytic skills. And I think one of the big drawbacks in the system that we have today is that we don't truly encourage autonomy and self-approach and self-thinking. So in our lab, and I see with these webinars, this is certainly being encouraged, and it's wonderful to see that we're allowing for that. But at our center, we work very closely with our physicians, and that we're ultimately responsible for not only the patient success, but also the success that we post on SART in front of all of our new patients, perhaps. And so part of our responsibility is, one, financial and emotional stressors that we induce on our patients. So if we're cycling our patients through over and over again without understanding truly how to improve their outcome, then we're providing a disservice to them. So yes, as scientists, I think we owe it to ourselves to continue to learn and grow. And then, of course, to our patients and our physicians, who are also our customers, to then make sure that we're presenting them with the best possible laboratory situation that we can, and giving them all of the feedback from the lab so that they can take that back to the patient and make a more educated decision on whether or not a second cycle or a follow-up cycle is then the best option for them.
Thank you so much. Any comments from the rest of the panel?
Yeah, I think it's really important to know the length of the stimulation. And I think many of the longer stimulations end up with poor oocyte quality, poor embryo development and blast development. Also the progesterone level at the time of HCG, I think that's very important. So I'm always involved in those decisions, and when things don't go according to plan, always look back at that and look at AMH, things like that, because we really don't have an AMH cutoff at our clinic, which I wish we did, because we occasionally get AMHs, 0.1, 0.2, which I think you get very poor stimulations, and then poor oocyte quality, poor oocyte numbers, quality, and development.
Excellent. Any other comments?
I would agree with David and Sheila as well. I think I really appreciate our physicians sometimes giving us a heads up to say, hey, here's what this patient did in the past, or here's how the stimulation went. Be on the lookout for this. The flip side of that is obviously if something comes up during the cycle, we're going to approach the physicians and say, hey, the eggs are not mature. The eggs look like this. They look like that. With sperm, you can always have them collect another sample. With eggs, you have to work with what you have to work with, as Bill so elegantly showed in some of his videos. And when we report out fertilization and embryo quality in the morning, we also look at, if it's something we were not expecting, we look at the previous cycles before we send the report out. So we can say this patient is consistently has poor blast development. And I think communication is key.
Thank you so much. Any other comments?
I'd like to add that one of the things that I've, with ASRM, I don't know, I'm sure most of us did the virtual ASRM, and some of these webinars we've done over this summer and fall. I've seen some presentations where 1PNs are coming up diploid and euploid, where historically I have not kept 1PNs from ICSI. There was a great abstract at ASRM where showing 3PNs, 14% of those embryos were euploid. I haven't cultured a 3PN in my entire career. So, I think the more we think we know, every day I'm learning something new. And I love how Kristen put it. There's a lot of right ways to do IVF, and it's so true.
Debbie, just in case you missed the question, I was asking whether an embryologist needs to know more about the patients and the stimulation protocol and any pathology of the patients while doing the work of ICSI and embryo culture and all that.
Yeah, I'm sorry, Nabil. One of the comments I'd say to David and the audience is, we see some of these people with low AMHs, and I liked Kristen's slide where by age the euploidy rates. I don't think the euploidy is going to change in those patients. If you're 35 with a AMH of 0.2, it just tells you that you don't have very many eggs. But I don't think the euploidy rate is going to change in those, and we should give those people a chance. Some of these older patients, I think it was around 9% euploidy rates in the greater than 40, somewhere in there. And those things we can't change. So it is good to know that ahead of time. If you ever input data into SART, I learned so much from inputting data into SART, because for the first 20 years of my career, I never put any data in. And now when I put that data in, I actually have a feel for what is happening with those patients and different types of stimulations, as David mentioned. It's good to know.
Thank you so much. Debbie, were you going to make a comment?
I was just going to say, I think the more information we have, I think it never hurts to sit down and evaluate it and look and see if, there might be a trend here. There's something going on. The history of the patient, I think, is always helpful. We're not the doctor, and we don't pretend to be the doctor. So we always definitely kind of turn our guidance towards, the doctor. But I think that I appreciate it a lot when the doctor does kind of turn their guidance towards our expertise on our end, because it's all one big puzzle and we're all a piece to the puzzle. And if we all work together and talk about, and like you said, communication, and we're all aware, I think it's really important. So hopefully.
But do you think stimulation can impact oocyte quality?
Do I off the cuff think that? Yes, I think it can.
Do the rest agree on that stimulation may impact quality, oocyte quality?
Definitely.
Sure, absolutely.
Absolutely.
I mean, without doing PGT, I knew 20 years ago that if you trigger before day 8 a gonadotropin or after day 12, the pregnancy rates dropped out, were significantly lower. So like David said, I hate going out to those long cycles. I find that with the freeze-alls we do these days, that it does, if you can get a blastocyst, they tend to normalize with the FETs.
Very good. We looked at our rates of fertilization. I want to share this data with you guys to kind of see your perspective. We have not seen differences in fertilization rates in all ages, the same fertilization rates of going from under 35 all the way to over 42. But we've seen a decrease in donors, which is very surprising because donors are supposed to have really good eggs. Do you guys have any experience like this as far as not seeing differences in all ages or the egg donor side? And I'll take any response from anyone.
So I can go first. Fertilization is likely not going to be affected because that's not necessarily a that's not necessarily where you measure your ability of your embryos to then reproduce. So just an egg's ability to fertilize via sperm injection versus a conventional insemination method does not necessarily show much of anything. It has not shown development. It has not shown, really key is cell divisions and the rate of division, more importantly. So when that information is missing, certainly you can't use that very early on indicator as a potential measure of outcome. So unfortunately, that's not that fertilization rate is important for us, and we certainly track that in the laboratory because we want to make sure that our procedures are being performed correctly and across all technicians in a very measurable and comparative manner. It in no way indicates, the level of success in embryo development and usable blastocysts as a final outcome measure, at least in the laboratory perspective. So I would say, that's an important piece to measure. However, not necessarily direct relation to the developmental ability of the embryo.
Thank you so much. Any other comments on the different age impacts on oocyte fertilization? Have you guys seen any differences?
I haven't seen any difference.
Yeah.
No, I mean, when you say you're seeing lower with donor eggs, is it frozen donor eggs versus fresh donor eggs?
We did not track that information, but we know that whether you're looking at 35 or 42, the ability to fertilize is the same. It's all in the mid 80s. There's no difference, statistically significant difference between ages. It's almost like if you have an oocyte, it will fertilize for sure. What happens after that is what really matters.
Yeah,
Right.
That's interesting.
Totally.
Now, when it comes to the size of the biopsy, I know that some of you have emphasized that the biopsy should be big for a more accurate PGTA testing results. But I have also seen the other perspective that the embryologists try to pick as small as possible of a biopsy because they are worried about the implantation rate. Where do you draw the balance between the two? Size of the biopsy and a reliable results?
it's
I
a
think
tough
it
one.
comes from data monitoring. You have to look at your data, and we all know that you can't really say I picked 3 cells. I mean, it's very difficult because you're lasering or flicking or tapping or smashing or whatever it is we're all doing, and you can't necessarily, you're not hitting it right at the junction. There's cytoplasm coming out. There's other cells that have been abused in that process, and I think that it's up to each lab to really decide. Everybody says we shoot for 4 to 7 or 4 to 8 or something like that, but you need to monitor it. You need to monitor it, look at it by technician. You need to look at, like other people have said, survival rates and implantation rates. And once you've got that data from your lab, then you can move forward confidently. But I think without the data, you don't know. And if you get low implantation rates, is it because you used the wrong warming media, or you didn't load it right, or something like that? I mean, it could be a lot of things, but as long as you're monitoring it and following it through, make the data work for you.
And in your experience, does the size of the biopsy impacts the clinical outcome?
I've never done a study, taking a small, medium, and large myself. No, I would think if you took a too large, there are studies out there that have shown slightly higher miscarriage rates if you take too big of a piece. But how you actually know without staining the cells, for example, how many cells you actually have is pretty difficult.
Yeah.
But I do think that you can take too few, just like you can take too many.
I would say that, I think, I can't remember who said it, but when you thaw the embryo and rebiopsy them, that there's really not a big difference in the pregnancy outcomes. I mean, for those cases, that's a really great example. You're taking twice as much tissue because for some reason the first time there wasn't a result, and now this time there is. I don't like having to rebiopsy, but I would say that when I do rebiopsy, about 50% of the time they're euploid, and those guys have the equal pregnancy rates with our just regular biopsied embryos, frozen thawed embryos. I think vitrification helps with that as well.
Absolutely. When we first started doing thaw biopsy revits way back when on slow frozen embryos, the pregnancy rate was dismal with those. But with vitrification, it's really not different. So I'd agree with Tony.
Very
Yeah,
good.
I think the more trophectoderm cells you have when you do the biopsy, um, like like I do day 5 and day 6 biopsies with hatching at the time, I think the proportion of cells that you're taking is fewer, and I think that impacts the quality of the embryo and the implantation rate. Although, I haven't ran those numbers either, but I think if you have a fully expanded blastocyst with a large number of small trophectoderm cells, I think the proportion of cells that you're taking from that biopsy will be fewer than if you're having a smaller embryo with larger cells. I think you're going to be taking more proportion of the cells.
Yeah, if you have a tech in your lab that is showing is an outlier for euploid or aneuploid, and not much mosaicism compared to everyone else, and they're probably not taking enough cells, and their implantation rate may be different also. But look for outliers like Kristen said, in your KPIs. I mean, that's all you can do is analyze the data.
And are you associating the size of the biopsy with the mosaicism rates, Bill?
No, because we're pretty consistent on, kind of across the board. And I said I was pretty aggressive, probably the most aggressive in my lab, and I'm not an outlier. We don't have any outliers currently in the lab. I'm not saying that we have not or can, but that's why we do it on a continuing basis, just to make sure, over time that this does not occur. But I've had outliers in other things, but not biopsy.
Very good. So when it comes to ICSI versus traditional IVF, I know that you, Sheila, you mentioned cases of Y chromosome issues and other genetic that could be. Could you expand on that a little bit? And also I would ask everyone to tell me your ratio of ICSI versus conventional IVF and why you've chosen one way or another. And I'll start with you, Sheila.
Okay, perfect. Thanks. So yes, I in the past had worked at a program that we had done 100% ICSI on all cycles, regardless of whether or not male factor was presented. And this was just standard and built into the system. I don't believe that there was a very compelling reason scientifically as to why we did that, other than, it streamlined our processes in the lab and it just made it simpler as far as from a billing standpoint. Now, the lab I am at currently, we certainly don't do that, and we perform ICSI based on whether or not there is a significant male factor present, or if there is an unexplained infertility, which could come up in a poor to no fertilization if we choose not to go the ICSI route. So in an effort to save the patient another cycle, or financially help the patient, we'll go ahead and add on the ICSI on unexplained cases. So those are the two reasons why we'll do ICSI here at our center. Now, to answer your question regarding the genetics behind ICSI and the increased rates of genetic defects presented in offspring due to ICSI, my main concern for presenting that data, and so was to bring to light and bring to attention the fact that in a large portion of ICSI cases, there is a male factor present. There is an underlying reason why the male patient is not producing sufficient sperm, or the morphology is variable or, the motility is lower. And so obviously in cases where, it's not due to an injury, then there is an underlying genetic factor associated with those cases. And so when you're comparing the outcome of ICSI cases to the general population or to the population of patients which does not present as a male factor, then you're going to see an increase in, a genetic condition passed on to the offspring, likely because there is a genetic condition present in the patient itself. The true way to really do the study is to compare normal presenting sperm that has been used for ICSI with male factor only sperm used for ICSI, and then comparing those outcomes. But unfortunately, our SART consents, for example, does not present data that way. And so there is a slight misconception there, and it is part of our responsibility to understand the differences and understand what the data truly means and how to interpret it. And once we do that, then we can go ahead and ease some of those discomforts for our patients and help them understand that it's not necessarily the ICSI procedure that's going to cause a genetic defect in your child. However, if there is a genetic defect already present, like congenital by absence of the vas deferens in the male, then there is a chance that that could be passed down to the offspring.
Thank you so much. Kristen, do you want to, what is your rate of ICSI versus IVF, and is there any rationale behind it?
Well, for many years, we were in the 40s and then the 50s, and as percent, and then as we started doing in the early days of more what was called PGD back then, PGTM, where you couldn't have any sperm around, we did ICSI on all of those cases, and it just sort of stuck that way and then evolved. A lot of it was also because, we would do strict morphologies on the samples, Kruger strict morphology, and we had routinely, under 4%, like a lot of people do, and the recommendation was to do ICSI. So is that the best way? I'm not really sure, but I would say right now we're well over 90% doing ICSI. And if we get a conventional insemination, it's like having dessert at the end of the day, save it for the end, everyone's happy. It is streamlined, it is easier, it is faster in a way. Is it the right thing to do? Is it absolutely necessary? I'm not really sure, but we're also in a patient population that wants to take every advantage and maximize. We had this tool available and we didn't use it, and we didn't have good fertilization. There's some repercussions to that also. And so the risks and the benefits are explained to the patient, and the patient freely consents. We don't require it of any patients unless obviously there's severe male factor. It's not required to do PGTA, as everybody knows. You don't have to do ICSI to do that, probably not even most PGTMs anymore. But a lot of it, and including doing PGT itself, is a lot of it is patient driven. We explain, as I said, the risks and the benefits and give the patients the options.
Very good. Bill, what's your rates of ICSI versus
99.99, as close to 100% as possible ICSI. Good points made by Sheila and Kristen both. Sheila about doing a study with ICSI between normal spermic men and and male factor men. That's the thing that has to come out. You can't do infertile patients versus fertile patients. It's not apples to apples, as you said. But the reason that we do it is it through time, it gave us a 10 to 20% higher fertilization rate than conventional. So, why not go with the best for us? And that worked the best for us. It Conventional may be for another lab, may be better. But ICSI wise, it just worked better in our lab. You always have that occasional one that you get a failed fertilization, and I do not like to wake up to that. So I like to sleep well at night. You know, there's no guarantees in this business, unfortunately, but you know, if you have more than 4 or 5 eggs, you can pretty much guarantee you're going to get fertilization with ICSI. So I don't think I've ever had a case where I've had enough eggs where ICSI has failed. But I can tell you, we've gone 0 for 20, if not more, with conventional IVF. So that's really the main reason for me is I like to sleep well at night.
Sure. David?
Yeah, we do about 95% ICSI.
Oh.
And for the same reasons, we like to, we do see a lot of poor morphology samples. It is more streamlined. And we'd also like to know what the eggs look like maturity-wise. We do have, when we do conventional, the few that we do, we get good fertilization. This you don't know, of course, you don't know the maturity. You can tell the ones that are going to be germinal vesicles by the cells, but you know, you're going to have M1s in there that you really can't tell by the cells. So the majority are ICSI. The patients do want the best fertilization, and it's really, like everyone else says, I don't know if it's the best thing to do or not, but that's what we're doing. And we've done, of the conventionals we've grown good blast, we've done BGTA, and gotten great results. But I think that we may be doing more conventionals, but in the future, but I still think the vast majority are going to be ICSI.
Thank you so much. Tony?
Very much like all the other panelists here, we do really 100% ICSI on all of our regular IVF patients. That they're not required to do it. We don't charge any more for ICSI. I do it very much the same way, just in the transition. We used to do half eggs ICSI, half the eggs conventional and SEM. And when you got no FERT with the conventional and SEM, you were glad you did some ICSI, and just kind of transitioned to all ICSI over the years. I feel that I maximize my number of 2PNs and minimize my number of 3PNs. You know, my threshold limits for 3PNs was, you know, less than 10%. Now it's, you know, less than 5%. And I usually run around 0.8%. So I could even probably lower that threshold. The people I do conventional on, though, are my INVO cell cycles. And that's because we try to keep it simple. We've done that. And, you know, like Bill said, you know, I like to sleep better at night. I remember the days of doing, you know, a lot of conventional, almost all conventional, and you never knew what you were going to get the next day. And it wasn't uncommon to have 5 to 10% no FERT rates, you know, come in the next day and not have anything. And so looking at my INVO cell cycles, we're running about an 8% no transfer rate, really. And there's probably that group of people that just wouldn't get fertilization. So, you know, in their next cycle, you know, I would definitely, you know, we're going to do ICSI on them. And if they decided to do INVO, I suppose we could do ICSI on the INVO. I've done those as well. And but the standard is to do conventional on those cycles.
Thank you so much. Now, day 5 versus day 6 biopsy, or even day 7, what your experience is like in terms of euploidy rates and implantation rates, and would you biopsy embryos in day 7, or where? Would you prefer first to go with day 5 and then day 6? Can you guys give us an idea of how you manage this decision based on the day of the biopsy? And I'll start with you, Sheila, again.
Yeah. Okay, sure. We culture embryos from up to day 6. So we certainly biopsy on day 5 and day 6 equally. So we'll let the embryos sort of guide us as to if the embryos are ready for biopsy. Many of the panelists here presented data on, or rather made comments on, I think Debbie did definitely, on which embryos are just too early and too young and should possibly just be waited on. Certainly that's important. We'll look at zona thinning, we'll look at expansion. And so if the embryos are presenting with a high enough cell number where we can sneak away for maybe up to 8 cells, given the number of cells that the embryo has in the tracheoderm, then we'll go ahead and proceed forward and biopsy. We do culture up to day 6, no day 7 culture. We'll unculture at 140 hours post-insemination just to have a uniform timeline across all patients. So there's not variability there, and we can have data that is more comparative, and we're able to draw conclusions from. As far as, our euploidy rate from day 5 versus day 6, I will tell you, I did a very small, comparative study about a couple of years ago looking at that. I did not see a significant difference by age group between days 5 and 6. But of course, the numbers were very small. So it's very possible that if you have a larger N, then, or, you're looking at other factors, not just age, and day of biopsy, you'll be able to see a pattern and some differences. I wasn't able to see that in our lab in the small amount of data that I did. I think I only did that over a course of 6 months. So all embryos that were biopsied for all age groups. So I didn't see that difference. However, I will tell you that our preference, when we're considering embryos to transfer post-euploid status, and the patient has day 5 and day 6 embryos, will then revert back down to morphology. So of course, if we have a higher quality embryo as far as grading on day 6 versus day 5, then we'll go ahead and warm that. So we'll use that as a second level of, as a selection tool, so to speak. And that's kind of how we've done it and held, pretty steady implantation and ongoing rates with that.
Thank you so much. Kristen, what's your experience as far as biopsy dates?
We do see a difference in euploidy rate between day 5 and day 6. We do see a difference in live birth rates between day 5 and day 6 biopsied embryos. So we will always select a day 5 embryo to warm and transfer over a day 6. With regard to day 7, we do very little day 7 culture. We'll only culture out to day 7 if they didn't have anything to freeze on day 5 and day 6, and they look promising. So, if it's a 1AA on day 6 and they didn't have anything, we'll go to day 7. It's really a case-by-case basis. I think, there are a lot of programs that culture everybody out to day 7. I think obviously it's a lot of extra time and work for the lab, but sometimes that's a necessity, particularly in a really large program that has very long days of retrievals. That embryo may not actually be a full day 7. It may be a day 6.5 kind of thing, if the eggs weren't inseminated until very late in the day. So I think one of the downsides too is if you culture everything out to day 7, those are going to be your least preferred embryos to transfer, and they may sit in your freezers and never get transferred. So I think it's difficult to get really great data on the day 7 embryos unless they're into your rotation for transfer, because how many embryos is a patient really going to have? If they have 4 or 5 euploid embryos, the day 7 is going to be probably the last one chosen, if ever.
Yeah, I'm gonna share with you guys our data on day 5, 6, and 7, and then I'll take the inputs from you, Bill, and then David and Tony. Let me just share the stats that we have. So these stats are comparing day 5 and day 6, and we're looking at 28,000 embryo versus 19,000 in each set. So 28,000 from day 5, and then 19,000 from day 6. So euploidy rates, all age group, 57%, day 5, 48%, almost 9% less in day 6. If you look under 35 years old, 64, that's for day 5, and 59 for day 6. If we look at, let's choose a day 6 versus day 7, then you're gonna see also differences. So day 6, all age groups, as we said before, 48, day 7, 38, 10% less. And under 35, we're talking about 59 versus 54. And that's summarize the differences. So day 6 is better than, day 5 is better than day 6, and day 6 is better than day 7 as far as euploidy rate. And then I'll take your comments, Bill, about your preference and how you manage the biopsy data and all that.
Yeah, sounds good. Thanks. Like I said in my presentation, without hatching on day 3, the majority of our biopsy right now is currently day 6. I would say it's probably, if I was doing percentage, and we are 100% go to day 7. So everyone goes to day 7. However, we're real strict on what we do on day 7. If it's a 43-year-old and that's her only embryo, that's biopsyable. If it's a BB, we're going to do it. If it's a CC, we're not going to do it. Now, then take someone with egg donor who we did 12 between day 5 and day 6. It's got to be a beautiful embryo for us to do it on day 7. I mean, it's got to be top quality AA. If it's not, we're not going to do it. They have enough, is our thought. But we culture everyone out there. There is a difference in euploidy rate, pretty similar to what you showed. But that doesn't mean we give up on those day 7 embryos. Again, for some of those patients, that's all they have. Have we had a pregnancy, a successful pregnancy? Yes, we've had. So, you know, that's the thing. I would say if it was 0, we might not do it anymore. But
if you have to choose between a good-looking embryo on day 6 and an okay embryo in day 5, which one would you transfer?
If it's one stage difference, so if it's let's say it's a 3AB on day 5. So a 3 for me is going to be a late 3. I'm afraid it's going to be hatching the next day. This is how our system works, though. We do day 7s first, day 6s next, then day 5s. That's how the biopsy goes for the day. So by the time we go to day 5s, you know, it could be, hey, this 3AB may be hatching tomorrow. We don't want it to hatch. So if I do a 3AB on day 5 and I have a 4AA on day 6, I'm taking the 3AB to thaw first.
Okay.
So we do day 5s, but if it was a 3BB versus a 4AA, we're taking the 4AA. But if there's 1 degree separation, so to speak, there, we're taking the day 5.
Very good. Thank you so much.
Yeah.
David?
Yeah, we do the majority on day 5. If they look really good the morning of day 5, we will do them. If we have 3 AAs, 3 ABs, you know, before noon, we'll do them. But a lot of them we'll do in the afternoons of day 5. We'll do late. We'll do, you know, after 3 o'clock, 4 o'clock, 5 o'clock, to let them get to a good stage, because we do see a difference. We do see better rates from day 5, but we do I'd say we do 70% day 5, 30% day 6, less than 5% day 7. So we're real picky on day 7s, and again, if it's the patient that had very few, maybe a 1 day 6 and one that looks like it might make it to day 7, we'll look at it. And if it's a BB or better on day 7, we'll biopsy it. But as I said, we're very picky on that. But I agree that day 5, we preferentially pick day 5s when we do the FETs, and then day 6s, and then last if there are, and unless all they have is a day 7, that would be last.
Yeah. And when you say day 5 better in outcome, are you referring to implantation?
Yes.
Implantation, right? And have the rest seen the same thing? Day 5 are better than day 6 in implantation as far as implantation potential?
Yeah, I wouldn't say it's that significant though for us, but there's a difference. Yeah.
Okay. Tony, what is your perspective on this?
Well, we actually, and I'm interested in your data because just it sounds like Bill, we have a few more normals on day 5 that versus day 6, but it's not chi-square significantly different.
Yeah.
So I'd be interested if your data is chi-square. I mean, just because it's 9% or 8% doesn't mean it's statistically significant.
Correct.
I don't think so. For me, I look at that. We do about 50-50 day 5 and day 6.
Yeah.
And I watch that data because, like Debbie alluded to, I noticed that we saw a push more to day 6, and I know my implantation rates are better on day 5. So, I bring that up to the team, and, I'm not accusing anybody of being lazy on Sunday, but at the end of the day, hey, if it's ready on day 5, you're paid for the day to finish it out and do it. And so I noticed it normalized. Things kind of came back to normal, 50-50. I don't go out to day 7. I did some day 7 transfers years ago with really poor results. On an occasion when I have this patient that just really needs, she's, just, nothing there, just kind of, throwing the kitchen sink at it. I have gone out to day 7, but I haven't actually biopsied at day 7 in the lab. Something I found interesting, and I don't know, I mean, maybe the panelists may have some ideas. When I did fresh transfers without PGT, I did not have a significantly different pregnancy rate with my day 5 versus day 6. I was early adopter to blastocyst transfers back in the mid 90s. We used to culture embryos on co-culture to make blastocysts, and there was not a difference between day 5 and day 6, fresh or frozen. And then when I started doing PGT, I actually do, it's not quite significant, but it's like P, equals 0.06. It's really close to significant. And, if I had 29,000 embryos to look at, it probably would be significant at this point. But I do have a lower. So as a rule, it doesn't matter what the grade of the embryo is on day 5. We take the day 5 first. And the day 6 is always the secondary embryo, no matter what the grade is. It could be AA on day 6, but we're picking the day 5 first.
Thank you so much.
In the bell curve of life, a lot of things tend to be BBs.
Yes, yes.
Just to make it easy.
That's great. Any other comments before we wrap up the webinar?
I think, we said I have a couple of comments. I think we said in this discussion here with this last question, it's so interesting in the responses and how much we've learned just in this little part is that, it's really just not enough looking at day 5 versus day 6 when you're comparing outcomes of euploid embryo transfers, because some of us culture to day 7, some of us will biopsy early, some of us will hold off and biopsy late. So there's so much variability, and it's just not as simple as, well, is it a day 6 or is it a day 7 or is it a day 5 embryo? So if you, to truly answer your question correctly, I believe we need to incorporate some other variables into this, perhaps something that's more measurable than just the days of development. For example, grading is subjective, but it's certainly a good tool. I wish we could adequately and correctly measure the number of CHOPE cells in an embryo prior to starting our biopsy, and then measure the amount of cells taken. There's even variability in techniques, as we just saw in our webinar today, of embryo biopsies. So that all of those variables, if we could place them into a statistical tool that will analyze our data for us, we would see that perhaps it's not only a variability caused by the day of development, and there are other factors associated with that have an impact on outcome. And so, of course, I'd like to not only look at implantation rate, but also the rate of loss, fetal heartbeats, so on. And that's certainly key. So this was really informative for me as well.
Thank you so much. Any other comments?
I just want to make one comment to the people listening to this, because these panelists have all been doing this for many, many, many years, and make everything look really simple, and it's really not simple. And as a new person, Sheila alluded to it a little bit, be patient with yourself, be patient, in your learning, and give yourself the time. And it can be frustrated, but we learn from our frustrations, and to just keep at it, because the more things you can do, the more you benefit yourself, the more you benefit your lab, the more you benefit your patients. But take your time, learn it the right way. Don't hesitate to ask for help. And like I said, just be patient with yourself and give yourself the time. It's hard to do, but we all expect ourselves to be perfect. And you're watching that senior person in your lab who's sucking and flicking and doing all these things like it's nothing, and it takes a long time to get to the point where you can do those things. So
yeah, very good. So before we wrap up, I would like to give you guys a minute to introduce either you or your organization or any other program that you are launching. I know that, Bill, you have an exciting training program to mention. So I'll give you guys a minute to do that. And I'll start with you, Bill.
Oh, sounds good. Thanks. I've been, I'll pitch the old man in me first, which is the lab director here at San Diego Fertility Center. I've been with one of the original docs since 1994. So we went private in 2000, and I've been at San Diego Fertility Center since 1994. West, so the World Embryology Skills and Training is our new venture for Debbie and I. We're doing a little bit different than Tony and Kathy Miller do. They do some specialized training. We're trying to recruit new graduates to our field, and then we want to train them with a pretty aggressive program. So ours is looking at a 3-month program to get someone who doesn't know anything about clinical IVF and get them into a lab and be a helpful worker bee, so to speak, in all aspects. So we're going to have different types of equipment. So in case they go to a lab with a certain type of equipment, they're going to be trained on that. So we're real excited about it. Again, we're really looking to recruit new people to our field and get them trained. That's our hardest thing these days. I learned on the job. Most of these people probably have too, but the way our business is growing and developing into, an analogy from family farm to corporate farming, so to speak, we don't have the time to train. It's tough to train these days with the volume that we have. So that's it. I probably took longer than a minute, but we're real excited about it.
Oh, well, thank you so much. I think it's awesome. It's an awesome program. David?
Well, I've kind of been all over the place. I've been in North Carolina the longest. I've been several clinics in North Carolina, Wake Forest University, and now I'm at Atlantic Reproductive Medicine in Raleigh, and I've been there going on 3 years. Direct a couple other labs around the country, and real interested in setting up new labs and have been involved in that a lot. So trying to do as much research as I can, and just staying busy. It just seems like things are busy everywhere. So as somebody said, trying to get things done, everybody's worried that things are going to shut down again. So it's just, we're nonstop.
Thank you so much. Sheila?
Thank you. Yes, so I direct a program in the Dallas-Fort Worth area in Frisco called Dallas IVF, and we're a five physician program. I've been at this center specifically since 2012, and before that I was in Denver. Recently here I've expanded a little bit in that I've worked for as a panelist for NASA, and I have learned so much, and research is truly addicting. It really is like a drug. The more you know, it seems like, oh my gosh, there's so much more that I need to know. There's so much I don't know that's out there. So I certainly I'm trying always to improve on the amount of knowledge that I have, and then certainly try to gain knowledge, not only from, these experiences, but also through other panelists like yourselves. So I certainly, I'm so feel privileged to be a part of this group here, and thankful to you guys to be able to hold these seminars together. It must take an enormous amount of work. And then I've recently also started directing a lab in the San Francisco area, so that it just all in all adds to the knowledge of how differently we perform IVF, and also brings to perspective that regardless, we are in our own way able to be successful, and there are variable ways, and certainly they all have their pros and cons. And then the last thing that I probably would like to say is that these programs that are now out there, like Tony Anderson's and Belinda Bivanier's program and Kathy Miller's program, are amazing. We are so grateful for those programs, because you're right, in that we're so much busier than we used to be back in the day. IVF used to be straight IVF with a fresh embryo transfer, and then if there's anything to freeze, great, and then there would be an FET to follow years later, hopefully. But now with all of the added procedures, ICSI, split cases, biopsies, I mean, it's just, the amount of workload has just quadrupled, really. And so the time to train a novice embryologist has gone from what was 1 year maybe to now maybe 3 to 4 years on the job training without, just a fresh graduate. So, and also, we're looking into these young embryologists that may not want to put in the effort in the beginning, because there's a breaking point for everyone, and they may not be able to truly survive that because the job is very stressful. So I'm grateful for those programs, and I'm hoping that more and more of our young embryologists will be able to take advantage of them, and ultimately it'll help us as an industry.
And you mentioned NASA. Is that a embryology driven program? Is it space program? Embryology in space?
So NASA we actually did a webinar on this last week or 2 weeks ago, and so NASA has a space biology program, and I don't know if many of the people here or the audience is aware that the International Space Station houses experiments, and there has been an astronaut or a team of astronauts on the International Space Station since November of 2000. And so because they spend 3 to 6 months at the International Space Station under these stressors of microgravity and, space radiation, of course, one of the things to consider is their reproductive success. And so NASA has taken initiative in that they're providing grants to research programs that look into ability to reproduce post-exposure of microgravity in men and women in variable age groups, length of exposure, etc. So I happen to be a panelist in one of those review sessions where we had research proposals from postdoctorate students, so really high level, for different tiers of awards, and it was phenomenal, the amount of information. And one of the comments and questions that you had was fertilization was not affected. Well, in that program we noticed the same thing. There is so much data out there that post stress exposure like microgravity and space radiation, fertilization is not impacted. However, blast development is significantly impacted and lowered. So it's just fascinating. I mean, we're so focused on IVF. There's just such a broad application to our knowledge.
Yeah, absolutely. That's fascinating. Thank you so much. Tony?
Yeah, thank you, Nabil. And thanks, Riley, for setting this up and helping us get this going. Yeah, I've been in fertility since I actually started cloning cows in the early 90s, and it's really a small world. Bill and I used to work for the same company in cows, and then I ended up working for the same company in humans. So it's a really small world. He and I used to work for the same guy out in California. But yeah, 30 years later or more, I been building the career, and I love this. It's such a rewarding field. I started a few years ago wanting to train people, and you know, setting up an IVF lab is very expensive. Setting up a training lab can be even more expensive because you don't just have one micro station; you have to have multiple micro stations, and so we're been at it for about 4 or 5 years now and building that. So it's been an exciting venture, and I'm excited to be in my own space now. I've been having to do just single one-on-one training. I'm hoping to do more larger groups since I have a little more space, and possibly even some of the long-term, looking at for people that, much like Bill mentioned, to like an income sharing agreement where people can come in, get trained, and then get them placed in labs. So there won't be any kind of placement fee. It'll just help them find jobs, guaranteeing that they'll find them a job at the end of the day. So I'm excited about that. Going to probably blaze out my career doing something like that, and hopefully add some research to the mix along the way.
And I'm sure that's going to solve some of the challenges we see in shortage of embryologists. Right? There's such a shortage in the IVF field. So hopefully that would help solve that problem. Mm-hmm. Debbie, tell us a little bit about you and about your training program.
Okay, I missed what Bill said, so I'm sorry. I had to step out. Yes. Well, my history is I started in the early 90s as well. I've been around the block. I was in animal science, like I think a lot of us were. And I started at Nashville Fertility Center. I was working for Melanie Freeman. And when I found myself in Central California a few years later, and there weren't any fertility clinics, I wanted desperately to stay in clinical embryology, but I was in Central California at Cal Poly State University. And I started writing grants, and I set up a lab and started teaching embryology at Cal Poly, and started a program where students could do research after they've taken my course. And it was an intensive 5-unit course where they learned all aspects of embryology over the 10-week period, and placed a lot of embryologists through those years. I was there for about 11 years, and then desperately wanted to come back to clinical, and was in clinical for the last 11 or 12 years in San Diego, part of that at San Diego Fertility Center, and the other part at La Jolla IVF. And I've recently left La Jolla IVF to start my training center. So I've kind of gone full circle: training, clinical, now back to training. And kind of like Tony said, I'm kind of this will be like how we kind of finish off our career, is kind of training up that next generation. I know our field is so desperately in need of trained embryologists. And I know Tony is an awesome trainer, and I know there's other programs in the country. And I think our goal is to be more recruit embryologists right out of college, those bio-sci majors who don't know what they want to do or didn't get into medical school, who actually would probably really love the career in embryology. I've given guest lectures at universities where students had no idea. They've never heard of an embryologist. They didn't even know it was out there. And they're so excited about a possible career. So hoping to stimulate some excitement in the university field and recruit some embryologists, because our field is growing. We're going to need more embryologists. And a lot of us old guys that have been around since the 80s and the 90s are going to start retiring. So we need some people not only to fill the shoes of those that are retiring, but also fill the new spots that are opening from our field that's growing so rapidly. So hopefully between all of us, we can get some new brains in the lab.
Absolutely. Well, thank you so much, Debbie. Thanks, everyone. I would like to, express my gratitude and appreciation for your time and your dedication and your focus in clinical, in helping patients and helping them improve their clinical outcome. With this, we're coming to the end of the webinar, the workshop. Next week on Wednesday, 3 p.m. Pacific time, we have another session. This time is a discussion on fertility preservation. And hopefully I can see you there next week. With this, thank you so much for joining us, and I will see you next week. Thank you.
Thank you.
Thanks,
you.
Nabil.
Thanks, everyone.